सीनियर पर्सन को ज्यादा पसंद करते हैं क्योंकि वैसे को आप कहीं और लगे रहते हो आपकी क्लास में आ जाओगे
ठीक है सर। सर
मेरे पास तो यही का है तो उसने ले लिया फिर
देने के लिए तो मेरे पास 2-3 फोन आ चुके, 4 और फोन आ चुके हैं। मेरे पास है ही नहीं, मैंने कहा देऊं कहां से, मेरे पास है ही नहीं।
स्वाति को भेज
मेरे पास है ही
स्वाति ने
नहीं। कई बार ये तो सॉरी
मेरे घर में स्वाति को मोबाइल
So hello everyone. So we can start the meeting. So it's on YouTube live as well as Zoom also. So Swati is being stuck at Parliament, so she could not come today. So today we have two interesting cases. First is being delivered by Dr. Chaitanya. He is a site consultant at Max Specialty, and case is being moderated by Dr. Manisha Dasi. Manisha, as you all know, एक mic दे दो मैम, ठीक? So to chair the session, we have Dr. Naveen Atul with us, and Dr. Jha will be joining soon. He is in Dharmshala right now. So from Manisha, just try to introduce our speaker and we'll start the session.
That we have interesting case of anemia, which I must share with you is possibly in next case of the series, which we have this situation which we have faced in the past 24 months. We'll see as the case unfolds. The presentation is being done by Dr. Chaitanya. Dr. Chaitanya, he is an associate consultant at the Department of Pathology at Max Specialty. He has completed his BNB specialization from Max Sapien and his primary specialty is pediatrics. So Dr. Chaitanya will be going through the details of it, and then we can discuss on what all we have been facing. We sharing our experience. Dr. Chaitanya.
Thank you for giving me this opportunity to present a case of anuria. So my patient is a 20-year-old resident of Ghaziabad with no previous comorbidities, present with fever which is of high grade initially and which is not issued with the chills, and there was no diurnal variations. The fever was associated with pain abdomen, which is of 5 dose, which is of epigastric origin and crampy in nature, and there was no radiating and referring pain. It was associated with multiple episodes of vomiting for 4 days, followed by loose stools, and followed by the blood in the stool from the last 2 days. So he was, for the above complaints, he was even admitted in the outside hospital, and he was being managed symptomatically because at the time of admission in the outside hospital, he was found to be dehydrated and he was being given plenty of IV fluids. And then in the investigation, he was found to have hemoglobin of 4.2 with a the picture of pancytopenia with deranged LFT and creatinine of 1.79. And at the same time, he was found to be a for IgM positivity. And probing here, he has been told that he had a history of ingestion of Golgappa. So that may be the culprit in this patient. And for this, he has received 2 units of LDP-RBC. After which hemoglobin got stabilized around 7.2 grams and platelets were in the range of 60,000 and creatinine has been in the range of 1.79 mg per deciliter. And after which the patient become anuric. The anuric phase lasted for about 3 to 4 hours. Then at this juncture, he was referred to our Max Superspecialty Hospital on 7th. So when he got admitted on general examination, he was alert awake. There is significant pallor and icterus is also seen. There is no edema, no lymphadenopathy, no rash, no purpura, no joint swelling, no oral ulcers. On vital examination, the pulse rate is around 90 beats per minute with blood pressure recordings of 126/79 in the right upper limb in the supine position and saturations of around 90% on room air and 96% on 10 liters per minute. On the systemic examination, the respiratory sounds, examination of respiratory system with the vascular breath sounds. For abdomen, there is no organomegaly. CNS, no focal neurological defects, and cardiovascular system, there was no pericardial lip and there was normal heart sounds. So patient was on the Foley's catheter per IV line when he visited our hospital. So after sending all the appropriate investigations, he was started on the broad-spectrum antibiotics, suspecting a sepsis with a multi-organ dysfunction and the ATN and supportive measures, and was shifted to ICU. And for the above neurological parameters, he was being transferred to the LDP-RBC and EPIC. Coming to the negative history, for the above associated complaints, there was no history of seizures or abnormal movements, loss of consciousness, stroke, headache, blurring of vision. To rule out possibility of TMA, we have asked all these details. No history of cough, breathing difficulty, palpitations. No history of dysuria, burning maturation, fever, chills, to rule out pyelonephritis, and to rule out the renal calculi disease. We have taken the history of lawn pain and flank pain, glavulia, which is not there. And with the possibility of glomerulonephritis, with the young age group, the ANCA being least possibility, and lupus or IgA nephropathy, we have a history of no color-colored urine, frothy urine, or blood in urine. All these complaints are prior to the presentation. And no preceding history of skin rashes, joint pains, or oral ulcers. No hemoptysis, redness of eyes, ear discharge, or significant weight loss. This is to rule out the ANCA. The no history of ingestion of antibiotics, antiplatelets, or intake of any complementary alternative medications. There is no history of trauma or recent surgery. Coming to the provisional diagnosis, with a background of this pancytopenia and renal dysfunction. So primary, we have kept the possibility of AKI secondary to the thrombotic microangiopathy. HS being the more common, which is more favorable than the TTP because the findings associated with HS, fever, blood stools, pancytopenia, active hemolysis, renal dysfunction. The points against the TTP are being that no CNS involvement. And coming to the second possibility, we have kept as because of this background sepsis, the possibility of ATN cannot be ruled out. There is a for this, the positive association being the fever, abdominal pain, loose stools, the multi-organ involvement, and pancytopenia. However, the other possibilities can't be ruled out, like renal vein thrombosis because of the pain, anuria, fever. But the blood pressure recordings were normal. There was no worsening proteinuria. There was no renal angle tenderness. So renal vein thrombosis is less like possibility. Still, the last possibility being the glomerulonephritis, the IRGN, lupus nephritis, IgA vasculitis, and ANCA vasculitis. The IRGN normally presents with a preceding throat infection or skin infection with a latency period, which was not there in this patient. Hardly there is a latency of 3 to 4 days. And lupus nephritis, because of the middle age, the presentation of lupus in a young male will be very severe. With the association of the pancytopenia, we have kept this possibility, but other findings are not there. The rash, joint ulcers, and joint pain, oral ulcers are not there. IgA and ANCA being the most common in the middle-aged group, this patient least likely to fit into this group. But because of this possible association of the crescentic transformation of the glomerulonephritis, where we can see the complete anuria, we have taken the history of this IgA vasculitis and ANCA, which are least possibility in these patients. But considering all the positive and negative history, these are all the diagnoses which we have kept in the mind. So for the HUS and TTP to rule out the different HUS and TTP. We have sent this Adams TF13 anti-factor H bodies and homocysteine levels. But at this juncture, we have not proceeded with the renal biopsy because considering its low platelet count and hemoglobin and ongoing sepsis. So on the investigations on the day of admission, the ABG is was showing bicarb of around 29.4 and lactates are 1.8. The complete hemogram is showing the pancytopenia with a nucleated RBC. And if you see the hemolytic workup, the peripheral smear is showing hemolytic picture like anisopyclocytosis, erythrocytosis, target cells, even the cystocells, the classical cystocells of the hemolysis, all these are present. And there is a deranged LFT with raised indirect fraction. Creatinine is 4.3 when he got admitted here. This is after the fluid resuscitation and after giving the dietary administration. And the procalcitonin levels at the same time, the other samples for the infective profile, such as procalcitonin, blood culture, stool cultures, and stool PCR were being sent at the same time. Dengue, HIV, all these were negative. The complements levels and autoimmune workup were sent. The complements lower level, the C4 being the more, lower pollen, ANA by IF and LIA and ANCA, all these were negative. And the hemolytic, as told before, this is showing classical hemolytic picture. Iron profile were normal, betas and folate were normal. Coagulopathy, there is derangement of PT and APTT, the D-dimers are normal. We can't send the urine and urine culture PCR because the patient is anemic. Coming to the course in the hospital, after suspecting this, we have subjected the patient to X-ray, ultrasound abdomen, and 2D echo. X-ray to look out any pleural effusion, any signs of consolidation or cardiomegaly. Ultrasound abdomen to rule out any primary kidney pathology such as CKD, which was not there because of normal sized kidneys and maintained CMD. There was associated mild splenomegaly and lymph nodes were enlarged, but which are subset.
ठीक है लेकिन बहुत मोटी हो
Today question ejection fraction of 55%, IVC is dilated. There is as such no pericardial effusion and there was no concentric LVHR by right ventricular pressures. So for this, the gastroenterologist opinion were taken and he was transfused 4 units of LDP, RPC and platelets, both SDP and RDP. And for the pancytopenia, mild splenomegaly and fever, the scrub and leptospira IgM were sent, which were found to be negative. He was started on the Lasix infusion because the IVC is dilated and he was already being given with plenty of fluids. However, his urine output did not improve and his creatinine and urea kept on increasing. And for the pancytopenia picture, without any previous history of any drugs or exposure to chemotherapy or radiation or any history of immunosuppressive drugs, the HLS has to be ruled out. So for which we have sent ferritin and fibrinogen. Ferritin is slightly elevated. It is in the range of HLS more than 500. Fibrinogen is not in the range less than 150. It is less than 150. It fits into HLH, which is also not fitting. Triglycerides are moderately elevated. So all these are not fitting into HLH. And then we got a call from the ICU team. So because the patient is anuric for a long time, so they want to have an opinion. So when we saw him, he was volume overloaded. So we have initiated hemodialysis. And we have sent us serum C4, all this as discussed earlier were negative. Blood cultures and stool cultures were sterile at this point of time. So considering the background of TMA with predominantly of HUS and which can be a classical HUS or maybe the typical HUS, the steroid doses were given and he underwent one session of plasmapheresis on 9th and was continued on the maintenance dose of steroid. And then later on, he underwent a hemodialysis on 10th via non-tunnel right HD catheter insertion. And thereafter, because as the hemolytic picture did not improve and the urine output has not picked up, so he was continued on hemodialysis and plex for the 5 cycles. Simultaneously, the hematology reference was taken for the pancytopenia and all the infective causes and the drug causes. After ruling out all these causes, the bone marrow aspiration biopsy was planned. We showed the reactive bone marrow, which is showing the trilinear hemopoiesis, megakaryocytic and erythropoietic hyperplasia. And obviously, there is a left sheet bilateral saturation to cope up the stress. And the bone marrow cultures were also set, which are sterile. So after these 5 sessions, the hematological parameters started improving and he started producing a little bit of 100 to 200 ml of urine. But his creatinine remained high. So he was continued on the hemodialysis. Meanwhile, the workup for the TTP and atypical HUs such as Adams 13 and anti-factor antibodies and cobalamin deficiency associated with HUS were homocysteine levels were sent. which showed normal range. And the platelets, but the TLC and platelets remained high because the initial phase, because of this sepsis, there is pancytopenia. And after a few days, as the course in the hospital progressed, the TLC and platelets increased because it can be due to the sepsis or maybe due to a steroid effect. Later on, because as the hemodynamic parameters stabilized and there were improvement of hemolytic parameters, he was shifted to ward on 17th of April. And then we have planned a biopsy on 21st of April. After the platelets have been improved more than 1.5 lakhs and the hemoglobin has been increased more than 10, there is no complement of coagulopathy and no active bleeding. And the procedure went uneventful and there was no post-procedure complications.
So we have seen how patient presented, a young boy who had had some food outside, presented with fever, with pancytopenia, severe thrombocytopenia, oliguric acute kidney injury. The possibilities which at the face of it, which we thought was possible, sepsis with MOTs. Now the focus of sepsis had to be found out. Now you may consider call it a specialist bias because I'm a nephrologist, I'm very sensitized to HUS. A patient coming with thrombocytopenia and renal failure will always look at HUS if at all it is there or not. And timely institution of therapy can actually be life-changing or might be a game changer at the outset. The other thing which we thought in the beginning was pancytopenia with acute kidney injury, history of fever, possibly atypical infections like Rickettsia, leptospira. There are few things which were going against the diagnosis. Like in leptospira, commonly it's a non-oliguric AKI with hypokalemia, which we didn't have. Rickettsia fever, again, it was mind because in this area we do find some amount of Rickettsia fevers also, but the test which was sent later, we found that they were not contributing. The other thing which we thought the initial bone marrow suppression was possibly part of severe sepsis only. But typhoid IgM also came positive. We are not very sure how sensitive, how specific was that. HUS has been rarely reported with typhoid. So we can't comment on that. Another important thing which he has also mentioned was HLH. Where platelets are too low, there is a pancytopenia plus renal failure. That is one thing which we considered. The relevant tests were done. They were not contributed. Aplastic anemia was another thing. That's why bone marrow exam was done. Aplastic anemia is associated with HUS also. Some patients with aplastic anemia have overlap with PNH, paroxysmal nocturnal hemoglobin. That's why the bone marrow exam was done without that possibility. So at the end of it, another important thing here was the complement. It was too low. T4 was okay, not bad. So a low C3 level with normal C4 as badly affected C4 would think towards involvement of the alternate complement pathway, which is the pathway which gets affected in atypical hemolytic uremic syndrome. That is why after an initial dialysis and stabilization of the patient, we stuck to the guns of HUS being the thing that we are dealing with. The pointers were presence of hemolysis on a peripheral blood stream, renal failure and thrombocytopenia. There were some soft pointers also like aretic count was high, indicating that bone marrow was still trying to help it. Whereas there was a hemolysis happening everywhere else, but the bone marrow was still responsive, which went against that initial thought process of possibly sepsis causing everything. In sepsis, the bone marrow suppression should have a low rating. So with these things in mind, we did start the steroids and plasmapheresis, and the patient did start responding in terms of hematological parameters. The kidney parameter was still same. They were still oliguric. That's why we did a biopsy, and it was not an easy biopsy. It was fully loaded, and we had to do in a sitting position. Biopsy did confirm the diagnosis of hemolytic uremic syndrome. This is the description. So hemolytic uremic syndrome involves the small blood vessels where endothelial dysfunction and complement activation ultimately lead to formation of small microthrombi within the blood vessel. Obviously, the circulation is affected and it may lead to necrosis of the tissue which is distal to the circulation, which is what you see here, patchy cortical necrosis. So the cortex of the kidney, which is the most important part, the glomeruli are present there only, the important functioning glomeruli. So they had undergone necrosis of up to 50 to 20% of the sample renal cortex, which is very significant. So the creatinine might never come back to normal, and we have to know where we are going to reach. Anyways, we continued with our plasmapheresis and other things and did reach a decent level of, although kidney function never normalized, but dialysis freedom, which happened after prolonged period of time. Now, why we have talked about this case is in the past, by memory, and we will be publishing this data soon, 5 patients where this was the profile of presentation. A history of fever with severe thrombocytopenia, renal failure, evidence of hemolysis in peripheral blood smear examination, complement C3 low, C4 opaque, and a clinical diagnosis of HUS, which was subsequently confirmed on a kidney biopsy. How they got triggered? Three of them had some by not doing contaminated water or how it has been prepared. The 2 of the patients had a dip in a river. And all these 5 gradually they were able to come out of that. Why it's important to know is when a patient comes like this, sepsis, MODS should not be the only thing on our mind. We should think beyond the obvious so that we can change the course of a patient's treatment. Here, a patient became dialysis free. That is a big thing for a patient. Suppose we had not done plasmapheresis or we had not given steroids, we are not sure whether he would have reached recovery or not. Where we can see the biopsy was showing necrosis of the tissue. We still can't make the necrosed tissue alive again. So, timely thinking about things which are more than obvious it's very imperative when we are looking at a patient with multi-systemic one. That was the premise of why this case considered.
So what's the biopsy done after starting the steroids?
Yes, because it was not possible before that. Patient had severe thrombocytopenia. Now, these platelets are functional. Like, if you go logically, patients may not have a bleeding because these platelets are working. There's nothing wrong with this. But still, why should we take this? Any which way our kidney biopsy, kidney is like a sponge of blood vessel, and you're pouring bleeding into the sponge of blood vessel. The possibility of bleeding will always be there. So better to be safe than sorry. That's why we did start steroid first and then did the biopsy and it was safe to do. Again, there was another patient where we skipped the biopsy because it was not safe. The patient, the hemolytic profile of the patient picked up much later after plasmapheresis session was completed. Biopsy, as you can see, did not change our line of treatment, but it did definitely make us sure on where we were going right. So you may not be waiting for the biopsy for instituting treatment. That's what I want to say. If you're clinically assured that this is the course of illness, how it is going, you have significant peripheral evidence of that HUS, please proceed with the treatment. You see about the biopsy data and it is safe for them.
Ma'am, I have a question. Like HUS, you said, is always an autoimmune or is it an autoimmune? Why did you start the steroid in the first place?
So HUS again, it has different types. One is a typical HUS which commonly happens after bacterial infection, which is E. coli, specific types of E. coli or sugar like now.
So 17 now, but
Your complement level.
Steroid.
Your complement level. In typical HUS, complement levels are not low. In atypical HUS, where alternate complement pathway is affected, the C3 levels will be very low, C4 may be slightly low, normal. This is a hint towards atypical HUS, where immune is indicated, not in the typical HUS.
You started this steroid because complement level was low and you suspected that it may be autoimmune.
Any biomarker for HUS?
So, not specifically. So, there are certain biomarkers which hint towards the diagnosis, but they will not be absolutely 100%. Like complement is one of them. To give you an example, yes, C3 is low in atypical HUS, C4 is not. Or C4 may be slightly low. Then you have SLE also, in which complement levels will be affected. How do you differentiate between the two? By clinical practice, right? So we do have certain hints which may lead you towards the diagnosis of HUS. Let me enumerate them for you. If you find hemolysis on a peripheral blood smear, if you see that the red count is high, indicating that the bone marrow is still responsive, you have a renal failure, commonly oliguric associated with hypertension, which is difficult to control, and you have a thrombocytopenia. So the definition of HUS is this only: hemolysis, uremia, and as you can see on blood tests, you will see complements which are there are indirect ways of reaching this. There are certain genetic tests which would lead you towards the genetic types of HUS, but obviously not all HUS are genetic. So this is a clinical diagnosis in which you take the history of the patient plus tests which are correctly towards in the line of the
One more question. Is there any HUS in which the steroids are contraindicated?
So it is typical HUS.
All the
Typical HUS. In the typical HUS, you don't have to do anything, gradually improves of its own. Normally it happens after a bacterial
So
infection.
suppose in that case we would have started steroid, it would have harmed.
It may prolong the duration of it. So this person will take more time to get it.
Sir, in typical HUS like E. coli, Shigella, we don't have to do anything. We just hydrate the patient, give the washed RBC. Don't give the unwashed RBC, washed RBC, and renal replacement therapy as per the requirement. That's it. And antibiotics are also not needed. That I am going at the take-home message. Three things should be kept in the mind in typical HUS. No antibiotics for the typical HUS. No anti-mutilating agents. No antiplatelet drugs. No anticoagulants. Nothing. Just give hydration and give supportive therapy like renal replacement therapy, which occurs in 50% of the patient may require hemodialysis in the typical HUS or in the atypical HUS. Give them hemodialysis, give them some time, they will recover. That's it.
Suppose plasma pheresis, only the hemodialysis.
That's what.
Same.
No, sir. I can't comment at that point of time because the C3 levels are low, C4 are borderline. So it means that it is a typical HOS pointing towards a typical HOS. So it is better to provide plasmapheresis. Once the renal shutdown has happened, whatever you go doesn't work. So it is.
For giving steroids. Then what is the role of plasmapheresis?
So plasmapheresis is for removal of the antibodies and all the pro-inflammatory, pro-thrombotic state. Even that's what I'm saying. Antibiotics should not be given in the typical HOS. But in this cases, this is different case because in the typical HOS, which is of E. coli and Shigella, the toxin produced will aggravate the case. If you give some antibodies, that more toxins will be released and more microvascular thrombi will form and endothelial injury happens. This is a different scenario. In this, we can give antibiotics. In fact, antibiotics prescription is allowed in certain cases of HOS, such as pneumococcal HOS and HOS like this, a typical HOS, where there is a mixed picture. You can't document in either of these. So at the initial point of presentation, there is no particular single point of investigation or the clinical marker which can say this is HOS or this is a typical HOS. So initiation of plasma exchange is definitely better and it has resulted in significant outcome.
Already provides an expression health information of new and plasmapheresis takes care of whatever has been already found. That's why whatever it is, the plasmapheresis is required as a precaution is commonly combined with an immunosuppression so that we can at least take care of the antibiotics.
So hemodialysis and plasmapheresis must be on the different days.
So we can do that on the same day also because plasmapheresis is kind of half of the session and standard dialysis for we generally keep a gap in between when the patient has died down for 6 to 8 hours. That time
So on the different
on
days.
So we welcome Dr. Ajay Dawson. Ajay, what is the experience of managing this HOS patient? Right, you mentioned that it is atypical HOS. So why you say that it is atypical HOS and mentioned that no CC
should have died discussed, yeah. But for atypical, that's what she was associated with the same facts that deformed antibodies, deformed those are already in circulation that can be removed by the plasmapheresis process and further formation is controlled or stopped by reduced by steroid use of steroid or and other supporting measures. Many times we can do same day also, we can do alternate days also. If we're doing like can we do alternate days, then depending upon the need of dialysis, if the patient is typically anuric, many of them are anuric. And it sometimes takes 3 to 4 weeks for the anuria to resolve. And many times have these patients have a partial recovery, ultimately also. So it's a type of an AKI there. And many of the AKIs will recover fully or partially. So this is one of the atypical or HUS is one of the types wherein the recovery is very, very sometimes partial or the kidney function, the GFR will improve, but it will improve not to the tune of like 70 or 80, but to the tune of around 30, the rate is around 3 or 4 baseline. Then after the improvement, I'm not sure about this specific patient, how the but all these patients over a period of whatever they have to recover, generally 6 to 8 weeks, many times up to 3 to 4 months, you can say late to date recovery. So beyond that, you can say this is probably become a new baseline for this patient. And all this patient will have same 3 to 5 ml of GFR for 6 months to a year. And they may go land into the next 4 or 5 years or sometimes 9 years also. Many of these patients. That is one.
For atypical HUS, all the symptomatic markers should be negative, like Procal, cultures.
Yes, because we are giving immunosuppression in time, so I mean, it's better that. So.
So there is screening is available of commission to do not antibodies there. So there is screening is there for HUS.
There are
Just to show.
Another fact is like hemolysis is one part. Then I had one patient about long been around 18 years. Was basically hemolysis was there all because hemolysis was this is PD deficit. So different types of hemolysis also can cause this, and this, that lady also was 3 weeks she was admitted. And we were perplexed, we couldn't do biopsy because the platelets are also low. Difficult to do biopsy in those patients. We just have to wait, keep on waiting. Finally, one day she started pouring, and most of these when they recover, doubling of the urine output will happen. So today it is 100 ml, 200, 400 like that. And this patient is not still coming to me in follow for any drug anybody writes, so she will come back. Yeah, this is pretty drug. Can I take this? So her rate is 1.2, 1.1. It has been one of the good performance. Like many patients will have like
Shigella, E. coli, sir, streptococcal pneumonia, Klebsiella can also cause. And there are unreported cases, so many reported cases of even Salmonella typhi, but very rare possibilities. This Salmonella typhi, मतलब this is contaminated water, sir. It can be anything, but in generally thought of it is.
we are not sure.
Sir, वो IgM कितना reliable है?
IgM is not specified. For typhoid goes and is better. When does it have to grow salmon typhi? Typhoid IgM rather than not specified.
Yes.
PK virus भी है। PK virus
So these are our post-transplant patients, sir, which are BK virus, CMV. These are post-transplant CMVs.
One of them had a combined hepatitis A and E infection. That is one case. Second, this is one Golgappe. There's another Golgappe lady called Golgappe. I don't know if they had same place, but she is now in recovery in the sense that now we are stopping her dialysis. And that was a prolonged wait, 2.5 months. Horrific ICU course, but gradually, possibly she was young and she had in the
bacteria grow कर जाता है।
I think this is a very important point. How to work up this.
Yes. So whenever we get a case of a TMA, so always we have to send the basic parameters such as complete hemogram, including the peripheral smear, retics, LDH, and the LF2 profile, which shows indirect evidence of hemolysis, like indirect bilirubin will be elevated. The haptoglobulins will be lower, then there will be cystocytes, which is more than 1%. And at this point of time, definitely you should eliminate the other causes such as autoimmune hemolytic anemia, which by doing the direct Coombs test, and always exclude the sepsis-induced DAC, and assess the not only the renal but also the extra-renal and end-organ involvement. After you have done all those things, then go for the ADAM-TS13 levels. ADAM-TS13 levels also, while sending this sample, you should be very cautious. There should be sodium citrate sample, and they should be done at -20 to -40 degrees. Preferably, when the lines with the heparin should be avoided, and the double centrifugation should be done. So after doing all those things, then we go send the ADAM-13 levels. If it is low, it suggested TTP. If it is normal, then go for the other tests such as stool toxins, cultures, imaging, viral test, HIV. All these viral markers, viral agents which you are seeing is BK virus, CMV. Mostly they are in the post-transplant setting. The influenza COVID-19 can happen in normal setting also, but BK and CMV in general, we see in the post-transplant setting. The autoimmune screening should also be done to rule out the lupus and as well as the rheumatoid, as well as the systemic sclerosis, Sjogren's syndrome, and as well as the ANCA vasculitis and anti-GBM, because they are associated with this TMS. And the metabolic component, if you have this raised homocysteine methylmalonic acid, to think a possibility of cobalamin deficiency, and definitely do the pregnancy test. And if the patient is pregnant, and the transplant rejection if the patient is a transplant. Then you come to the complement mediated TMA. Here, initially it used to be it is atypical HOS, typical HOS. Now the terminology has been abolished. Now we call it as complemented mediated TMA. Complemented mediated TMA, it is genetic or acquired. Genetic, because of these mutations in the complement factors, there are complement factors which promote the alternate pathway. There are complement factors which withhold or which protect from the overactivation of the complement pathway. So this factor I, C, H, I, B, these are all promoting factors. The factor D, I, they comes in the opposite way. They oppose the alternate pathway. So by sending this genetic testing, the other complement mediated TMA is antibody mediated TMA, which is particularly against the factor H. So, and then comes the complement proteins. You can send all these complement proteins of the alternate complement pathway, and you can analyze which side we are going, whether it is genetic defect or it is acquired defect due to antibodies. Anti-factor H antibodies assays also the same technique as the ADAM TS13. It should be frozen and it should be sodium citrate sample. So in this patient, we can see
due to paucity of time, I think we should conclude. And it was a very nice one. Please conclude.
Take home message: TMA is a clinical diagnosis. So don't ever think that TMA can be systemic. It can be also renal impaired in all these settings between transplant or hypertension emergencies or AFLA. HUS, definitely when there is predominant kidney involvement or requirement of dialysis dependent. Plasmapheresis doesn't help in MCP and streptococcal pneumonia. In the HUS, avoid heparin, antithrombotic, antimotolytic agents. TTP, when there is more CNS involvement and severe thrombocytopenia less than 30,000. And the agent we generally use is capolizumab, which targets the BVF. So think in a broad spectrum of view, apart from the sepsis, look at the complement levels, look at the infective profile and the autoimmune markers, then take a decision whether to go for steroid, IVIG, plasmapheresis, immunosuppressive therapy, or just the hydration. It all depends upon the clinical scenario, not on the blood tests or investigations. Thank you.
Last message, we don't need outside or don't take those of others.
Yes, sir.
That was a nice talk.
Thank you.
Thank you for it. I think a good round of applause to Manisha and so I request Ralivan sir to facilitate our speakers and chairpersons. Manisha. Very nice. Okay, आखिरी खाना होता है. Thank you for participation, and I think it was a very good case. And as a patient, I think Manisha is not admitted privately to you. It was not admitted privately to you. I think patient.
Gastro one was medicine. So because we come into picture later, initial presentation was fever with MODS. The other one was admitted under gastro was FAE positive. Patient gave liver dysfunction. So these are associations. We are not sure. There is always a difference between association and causation. So these associations have been.
I think it's a very good case. Actually, we should have a very high degree of suspicion, and if we with the hypothesis and kill it with it. So I think it's a very good thing. Thank you. Now we have a second case to chair the session. We have Ramdam Vidwanshi sir. Ramdam Vidwanshi is great because nowadays lot of Facebook and WhatsApp messages sir, and definitely it's an honor for that That's a great thing. Dr. Rajiman sir, sir. So today is a very interesting case of TAVI, and we have esteemed speaker from today's course, and we have heard you in some of the meetings, I think. So welcome to our forum, our physical efficiency session. Get the impression straight, first straight. Intro straight.
Yes, sir.
So Dr. Pratap Singh is DM Cardiology, Safety Medicine, and Fellow of European Society of Cardiology, Fellow of Society of Cardiovascular and Left Interventions, and Senior Consultant in Intervention Cardiology at Fortis Scott Heart Institute, Oakland. So welcome, Dr. Rahul, for on EDPA forum, and we would love to hear from you. And any comments from Dr. Chairperson?
I think Dr. Vibhuda, I also chaired two sessions like this with a all-rounder kind of this. So, welcome.
Thank you, sir. Thank you, sir, for all the kind words. Thank you, IMA East Delhi, for inviting me and giving a chance to speak in front of you. It is always interesting East Delhi. Yeah, East Delhi presentation. And it's always a pleasure to have a crosstalk with physician. I tell you, everybody who's a super specialist, the first love is always medicine. And the kind of interesting discussion you were having with the nephrologist, I was reading that why didn't I become a nephrologist and let us continue with all those beautiful slides and working on. But today what I'm going to present is a very simple case, zero contrast TAVI. The main thing what I want to focus is on aortic valve has always been a issue of contention between a surgeon and a cardiologist. So my take home will be two things. One, where a cardiologist should be involved, and second, the case which we did with practically no contrast. So this was a procedure we did along with my fellow Dr. Puneet. So first of all, severe aortic stenosis is a life-threatening and a rapidly progressing disease. After the onset of the symptoms, patient with severe aortic stenosis was survival rate as low as 50% at 2 years and 20% at 5 years. The partner trial demonstrated that 50% of the inoperable patient died 1 year without a valve replacement. It has got worse prognosis than many metastasis cancer, 5 years survival of breast cancer, lung cancer, prostate cancer, ovarian cancer, and severe inoperable aortic stenosis. You can see in this slide how much deadly disease we are treating. Why it has become important? As we see in the past, the life expectancy has increased, the economy has pushed, the patient now wants life that is beyond the usual 60, 70 years of the age. And that is why the focus is coming on the aortic stenosis. But there is a treatment gap. Risk of surgical valve replacement increases with age and comorbidity. 30-40% are deemed unsuitable for surgical aortic valve replacement. About 4.5 lakhs patients remain untreated, leading to about 80% mortality in 5 years. So there is a group of patients who are surgically ineligible and they have to be focused for the aortic stenosis and aortic valve replacement. This was the early confrontation. I will say when I started my cardiology around a decade back, this was the fight that we had with the cardiovascular surgeons. But almost now the fight has become so much reverse that the cardiovascular surgeons are now themselves going to learn TAVI because the procedure is so simple, easy, and for the patient, it is such a pleasure to walk away from the hospital 2 days without any major stitch and all. The standard option of treatment for a tight aortic stenosis can be 4. Medical treatment, balloon valvoplasty, surgical aortic valve replacement is the gold standard, 50 years established line of treatment. We just can't take it out. Transcatheter aortic valve replacement, our TAVI, whatever we call it. But here is the difference. This slide just tells what the work surgeon has to do on the right side with so many guys, so many wires. And this is a patient which we operate within next 3 years, he's able to mobilize. And this valve therapy is going on across the whole valves. Mitral, it is with the MitraClip and TER therapies, tricuspid, again with the clip therapies, and the pulmonary. The horizon is slowly and increasing, and in the last decade, the knowledge has become increasingly more there. This was the background. Around 21 years ago, this gentleman Alain Tremblay from the France basically started this thing, and then there is a revolution in such that now the cardiologist, the major practice has become a structural heart disease. Today, TAVR is becoming mainstream therapy. More than 1 million cases are done. 4.5 billion to 17 billion, the health estimate. It is expanding into lower risk and younger patient, advanced THP version, and driving the concept of heart team. Heart team means surgeon, anesthesia, the echocardiography guy, and the cardiologist coming all together in a particular case, deciding what is best and what is going forward. There is an evolution of evidence from inoperable from the partner and CORE trial, high to the partner and the COLVAR, to the low risk. The data is now emerging and data is coming more and more. So the basic when the heart team comes, and that should be the first step whenever the aortic stenosis patient is there, that a proper heart team is there, a surgeon and cardiologist should be part of the parcel of the decision making. And that's a tough task in a place where both are having a huge practice and a huge ego, and where you are getting to get both of them into the things. So age 65 less, more bicuspid, activity higher. Generally, they go for the surgical wall replacement. 80 plus, tri-leaflet, low activity, they go for the TAVR. But if we go with the guidelines, and this is what the exact take-home message should be for the TAVR patient, when you should refer for the surgical and when you should refer for the surgical wall replacement. There are two prominent guidelines, European Society of Cardiology and the ACC guidelines. First of all, we should know if the patient has got palliative care. He has got severe comorbidities when the intervention is unlikely to improve quality of life or prolong survival more than 1 year. That is true for any procedure, even angioplasty or CABG. The patient should not go. If the life expectancy is less than 1 year, he should be on palliative care. This holds for any intervention, in particular for the TAVI also. Transfemoral TAVI, the European says age more than or equal to 75 years, all patients goes to the TAVR. Or high risk for surgical aortic wall replacement, 8%. I'm just quoting ESC because they are more advanced in this thing. The gray zone is when the age is 65 to 75, the intermediate risk for surgery, it is a gray zone. Patient can have either one. Why the TAVR has got a lag? Because the trials are from 8 to 10 years. We don't know the longer, how much the longer the duration the wall will behave. It is a bioprosthetic wall for the way other ways around. Surgical aortic wall replacement, age less than 75 years and low risk for TAVR. Also very important to understand. As a cardiologist, the guy who has got hammer will always look for the nail. It is not the things. If your relative is less than 75 years, he has got an active lifestyle, surgical aortic wall replacement should be the first target. Age less than 65 years, definitely there is no question about it that a surgical aortic wall replacement should be there. So this is nutshell what the referral for the surgical or the transcatheter aortic wall replacement there. Now coming to the case. So what are the challenges when we go for the TAVR? It is simpler to the surgical wall replacement, but the main problem with the cardiologist is we still rely on the dye. We have to use adequate around 100 to 150 ml of dye, which can be a nephrotoxic. All the nephrologists are sitting down here and becomes a real problem when we are focusing in this subgroup of the patient. So here was the gentleman, 72 years, diabetic, hypertensive, COAD, CA esophagus, post-radiotherapy, CKD on medical therapy. Presented with typical symptoms, dyspnea on exertion, class 3 and 4, hematuria. The labs, hemoglobin was 9.8. The CRAT was 4.2. Again, a big no-no for anything that is related to contrast. Echo showed severe aortic stenosis. Mean gradient was 54, aortic valve area less than 0.1, and normal biventricular function. Heart team meeting was done. Surgeon himself said that TAVI should be the plan. Now the CT we did with the minimum contrast. These are the CT findings, and this is what the basic workup is what we require for a transcatheter aortic valve. In fact, now once we have the knowledge of structural heart has increased, we should also be getting all our patients who are going for aortic valve replacement also to go for the CT. We should understand whether the annulus is small. How much is the calcium? If the calcium score is more than 2000, the prognosis become different. So this is the initial what we did. Annulus measurement of, we did the area derived diameter and the perimeter derived, and we fixed our goal on 24.5 Merrill MyVolve OctaPro. The beauty about this valve is, I'm not promoting, but this is one Indian company. I tell you, last year I was in Milan for a fellowship for 3 months, and it was gladdening to see that Firangs were using 40 to 50% of the Indian valves down their shelf. And what an amazing moment that we are using a valve from the Indian company. So we had adequate sinus and STJ junctions were adequate. Calcium was not that much, 453. Bicuspid anatomy was there. The coronary heights were important. These are the parameters which we fix it even before we intervene. So how come the coronary and the structural, our engagement is different? In the structural, all the data is with us before we are going to the wall. Everything is planned, pre-planned as compared to the coronary intervention. The angle was favorable, and then what we did was, and you can see half an hour procedure in which a patient generally, if he had gone to surgical aortic valve replacement with all the comorbidities, how much time he would have taken. 2 wires were put, one in the non-coronary cusp, other in the other cusp. A pacemaker was put in. A valve was taken, mammoth dilatation was done. Valve was positioned at the nadir of the aortic valve, inflated, and the results of the valve. Half hour, the procedure is completed. Next day, the patient is out. That is the beauty of the procedure. And all the data on the table. The left side is the gradient prior to the procedure. The right side is the post-hemodynamic trace. Absolutely no gradient across the wall. Slight bundle branch walk, but that is accepted part of the transcatheter aortic valve approach. So our is the next step, expanding indication, low risk patient, the data is coming. Bicuspid, the data is coming. A small annulus, any intra-annular valve, even our intra-annular or a surgical, it is a high risk. So small annulus is generally the field that is now going for our asymptomatic patient. Data is coming on and on. So with this, I end. I'm open to any questions which I may be able to. Thank you. Cost, sir, is around 15 to 25 lakhs, 15 for the Indian total cost procedure, 25 to the Western wall. But that's the early days. As the cost, the therapy is increasing, the cost will further drop down. That is for sure. It has been approved by TPA. It has been approved by CGHS. That is also the news. In fact, in some government schemes, say in Rajasthan, that Bhamashah scheme, they have approved the tower. So that is really coming down good on the part of that.
This for surgical aortic valve replacement for 8% now. That is there is some calculation.
Yeah, STS risk is a calculator, sir. If you just get on the website or an app, you can get the things. So
the cost predominantly is of surgical technique, or is it the?
No. The wall is around 12 to 13 lakhs. That is how the thing. Because it's a newer technology of patent, it has, because of the Indian companies now into the fray, it has come down, because once we started, that was around 7 to 8 years back, the cost used to be around 25 lakhs. As the Indian companies have come, the price has gone to 15 lakhs, but it will further reduce as the government comes and intervenes more and more. So, okay, so limitations of tower, there can be 2 ways. You are asking me the peri-procedure or post-procedure? Okay, so post-procedure, what the thing that hold down it is a bioprosthetic valve. As the surgical valves were mechanical and bioprosthetic. Bioprosthetic have got a lifespan. Now, why we are putting more than 75 years? Because the data is for initial was for 5 years. Now the data is for 10 years. Data is growing. There is a limitation that the bioprosthetic valve may degenerate, and you will require a second TAV, that is a tower in TAV. So that becomes a slightly difficult procedure as compared to the index one. That's the one. Second, the coronary access become an issue because your valve is sitting across the coronary. That is the second part. Third, there have been post-procedure, even to the month around, there have been the data of complete heart block. That is also one there. Then there was initial studies that there is a stagnation of blood, which can lead to thrombus, that can lead to strokes. Post-procedure, 1 month around the TAVI. So these are the limitations, but compared to surgical, these are minuscule. That is what I will say.
Is this running of Java?
Yes, it is a synonym. That's it. It is done in the beating heart. In fact, once we are implanting the valve, what we do is we put, you see that we had got that temporary pacemaker down here during this implantation of the valve. See, there is a right side, there is a temporary pacemaker. We get the heart rate to beat further because it will drop the pressures. Our fixing the valve will become much more easier. So it is in the beating heart. Patient, and by the way, patient is in conscious sedation. He's talking all the times. There is no need for GA. So all the GA and all those things goes off and on.
In this case, you kind of tell the depth of the valve just on the pigtail and the calcification.
Yes, calcification and sir, these two, the J-tip we had placed down initially. That is what the thing was.
Extent of the wall without a contrast.
Yes, sir. That is what the whole thing was. So we require a contrast many times. There are two kinds of tower. One is self-expanding and the other is balloon expand well. Here we had used a balloon expand well because in that, if the contrast load we require is less, because you go and implant and come it out. Here the challenge was that patient had creatinine over somewhere around 5 and he was on the risk of the zone of dialysis. So we said, why not go for the zero contrast? And the beauty of the procedure is hardly half an hour. You can see 4 or 5 slides and the thing is on. Patient is back to the square. At present, the data is somewhere around 8 to 10 years. We have got the whole data. Yes, sir.
So the important challenge in this case was to see the depth of the valve, because if the valve is too deep, you may have a higher chance of complete block. So I'm sure only a very experienced operator can venture to do this type of atypical kind of thing. Because as you said, transfemoral, now we are doing transaxial also. So there are alternate access. So some patients may not have good femoral, so we can do it in other access also. But obviously, that's a learning curve. But I think very nice. So thank you, Dr. Yabul.
Thank you, sir.
So most important thing which I think we should focus on is in young patients, we should not go for TAVI, because I have had patients who are 65-year females insisting on a TAVI. I said no, TAVI not for you, because as he said, although now with the latest generation, the longevity will probably increase even with surgical bioprosthetic valve. Now they claim 20-25 years of longevity. So similar kind of technique will also be available with us. But till the time those data is not there, it is unfair to send a very young patient to them.
Absolutely true. Absolutely.
Mitral valve also, we have people are doing mitral valve replacement. Usually it is done in bioprosthetic. Because a similar valve is used, but there is, it's probably a little higher.
So, sir, may I? So basically, valve itself is a huge different. Aortic valve is the simplest of all. It is gear and you have to cut. When you deal with the metal, the valve is bigger. There are cordies down there. So the challenge becomes much more. Valve replacement, as sir rightly said, is the one thing that is coming on the horizon. It will come on the big way round. The other thing is that once you have a mitral valve that is leaking, the leaflets are not properly opposing. What you do is you just put a clip. The two leaflets are less like a stapler. They are clipped on. The procedure is known as TER, transcatheter H2H repair, or Mitra clip, and very good. And I will say mitral valve thing is excellent. The cost of the procedure somewhere ranges about sir. That is what I was last year for the Milan. That is the specific thing I was down there for. Mitral valve, sir, again, the approach is through the femoral vein side. We go through the right heart, we do a transeptal puncture, and we go to the left side. In fact, the procedure is much simpler in terms of complication than these kind of thing. It is more complex because the valve anatomy is different. So the traditional way won't lie, but the complication wise, the procedure, they are quite less. So very important question, sir. So what we do is once we come out with the TR device and we are out with the things, the wire is inside the things, the gradient is measured. Generally, the gradient is less and we keep it like that. But sometimes which happens without the mobilization, and we have seen on table that there the leak becomes too much. Or suppose a stitch has occurred, it has crossed to the outside the there. We put that because the wire is inside, it is 5 minutes job, put the device down there, ASD device, and we just close it down. But that is not a routine. Hardly 1% of the patient require that. And very exciting. And I will say the tower was around 10 years back. And now the things, the Metra clip is the next 5 years, 6 years. As we have seen the change of the patients that are coming now, patients want to live more because now they are more financially viable. And somebody who's, let's say a doctor who is want to practice at 75, what is holding him back? He will go for that. And that is why these procedures are becoming more and more common.
It's a wonderful case, and I have written from the voice. So in this age 75 plus, you have some positive fronts and EGFR is less, right? So there is a entity called contrastive nephropathy, and I think they gave those cases. Now, what is the current guidelines to deal with such cases of contrastive nephropathy?
So there is not a huge amount of data which says yes for the contrast related properties thing. But there's some amount of latest data which questions its existence if at all. If all it is there or not, do not know. It's if I have to look at how I practice, those patients who have comorbidities, like they have an CKD or they're diabetic or hypertension, elderly age group, those who are on metformin, ACE inhibitors, or SGLT2 inhibitors, in those situations, contrast has been associated with acute kidney injury. And mind you, I said associated. I don't know causation. So yes, I have seen that if I have to roughly enumerate what percentage, I would say 30%. That is why if at all a patient really needs a contrast, I don't say no. But of course, I do explain that these are the possibilities. Number two, I try to take off SGLT2 inhibitors, take off ACRBs if at all possible, optimize the patient, and then proceed. One thing which is definitely shown to decrease risk is maintaining euvolemia. So that is one thing. Apart from that, I'm not giving any other medication other than
Even metformin is not indicated, but contrast is given.
so there is some data that taking it off 48 hours before the contrast may prevent occurrence of mobility.
Again, very rightly said by Dr. Asi. So the idea is as we do zero contrast TAVI, so we do zero contrast angioplasty also. And the main idea is if a patient requires exposure to contrast, one should not refrain or one should not deprive that patient from that investigation. In fact, CT the contrast is intravenous contrast has almost negligible chances of intra-arterial contrast chances are higher. As he was saying, there have been studies both ways. Some say that it is just a myth. There is nothing like in contrast. But then we have seen patients going into renal compromise and they require a one or two dialysis and then become bad. So hydration is very important. There should be UVB, and there are studies that show that when you intervention measure the LVEDP and according to the LVEDP to reduce the patient, LVEDP guided hydration is probably the best. So just routine hydration also may not be very
There is a slightly related but unrelated topic that I also want to bring to notice. What about MRI contrast? Like whenever I say, so I get a patient for clearance for MRI contrast, I'm willing to give the clearance, but the radiology is not willing to do it. So MRI contrast in people who are less than 30 mils per minute of GFR is associated many years later with something called as nephrogenic systemic fibrosis. It does not cause acute kidney injury per se. If at all, it is an allergic reaction that might happen with paracetamol also. So with MR contrast specifically, if the GFR is more than 30, please go ahead with your study. If at all the patient is dialysis dependent, still you can do it because MRI contrast is dialysis. With CT contrast, dialysis does not do anything because if at all injury happens, it will happen instantly. We may dialyze and remove the contrast, but it is of no benefit because the injury had to happen, it has already happened.
MRI contrast and the CT contrast very identified. But what is about the low dose contrast that you be using this angioplasty?
Idea is the victim is if you keep the amount of contrast used less than the EGFR of the patient, then you may not injure the kidney too much. In fact, it's more than twice the EGFR. But we try. So we have now techniques as Dr. Duboda told. So we use intravascular sound to guide our procedure, and we do that ultra low contrast. So the only contrast that is used is during the angiography because you can't do an angiography without contrast. And subsequently, we use some techniques to kind of do the angioplasty without using any further contrast. And we have done cases where we have used 13 and 14 and contrast. It's something which now even the cardiologists, there is a paradigm shift in the thought process that we use minimum amount of contrast. And I think that should be for any procedure. May not be somebody who is at high risk or who is the comfort. For any patient, limiting the amount of contrast should be philosophy by the
I think the sector also like easy on going of CKD patient getting down to 2.5 those results, the excellent results. No competition as per se. Previously 5-10 years we were very afraid of doing our these angiographies with getting down 1.5 or 2. Now that things have changed radically, there is no casual contrast as well as from
As sir was mentioning, the techniques have also.
Yes.
That's hydrogenated. Hydrogenated contrast types have also changed. So the situation is much better.
So there were cases where patient had multivessel disease or LP dysfunction. And probably the renal compromise is also partly because of the LP dysfunction. If you improve the cardiovascular this thing of the patient, the renal parameters also improve. So that fear should definitely go out of.
Generally, what we have seen across the contrast-induced nephropathy and why the results have improved, sir, we are now very clear with the offending agents. So suppose you are prepping up the patient with taking of the drug, as ma'am has said, SGLT2, ARNI. Patient is hydrated prior well to the procedure, and that becomes the only thing that prevents the contrast-induced nephropathy. That is the only thing, not any drug. That has become, the knowledge has increased, and with the newer device, as sir is saying, imaging and all, that has the contrast load has now decreased. So as the understanding has increased, the CIN risk has increased. Second, very important point, for any patient which we take for the lab, Behran score is one, again, online tool. Just put the CIN risk and show it to the patient. That also very important. Third, the question, since it's a crosstalk, I will ask Dr. Manisha, what we have got impression, the contrast that we give during CT and the contrast during the intracoronary. The intracoronary is more harmful. The reason why is that so?
Those patients who are undergoing coronary contrast have higher comorbidities. CT contrast patients are well optimized. Also, what all are the set of patients where you could advise CT contrast? Any which way your pre-test probability is different. So it's the comorbidities which are changing.
So why this question has come again to us is the structural things. Once our patient for the structural disease go for the same thing. He goes for the CT with contrast, he goes the procedure with contrast. Definitely after the procedure with contrast, the rise is more. Probably also related to the hardware, the embolism, the shower going down to the kidney. That is also one thought process that comes to the mind. So yes, intervention contrast is really a challenge. Don't be in a rush for the patient, especially for the elective patients, the procedure, plan the procedure. That should be the dictum of the things.
Who take this topic, so the cholesterol emboli syndrome, which you're talking about. This we have faced more to the vascular surgeons, those who are doing peripheral angiography. And I have not personally seen many patients having this kind of issue with the CCU, but yes, the CTVSICU does have this problem.
True, absolutely.
Thank you, Dr.
Thank you, sir.
Thank you, sir. Thank you, Dr. for enlightening us about all these new techniques.
Thank you, sir.
Thank you very much. Thank you very much.
So I now request Niyukta was the first state speaker. Because I think the third or fourth time that we will listen to excellent. तो हम सेल थोड़ा बता दो इसको लेकिन आपको नहीं करता है ये हमें दे सर आपको डालने तो बस this final 1 minute of you and your addition to announce the independence award. So
How to save the,
how to save the plant, right?
so that will like.
Next image पे कर लेते हैं. So any guesses from this slide that who is this person? Achieving this so many accolades and awards. So I think this month's no surprises. So this month's EDP Champion Award goes to our own Dr. Amitabh Yadvanshi. Dr. Amitabh Yadvanshi. So I will ask Dr. Amitabh Yadvanshi to enumerate few things that you have done. I think in this year, this month's previous months.
Thank you. Thank you so much to the EDPA, and this is like homecoming to me. I think the first meeting when this auditorium was built, I attended that first meeting, and it has been a regular feature of this. And I'm so happy that EDPA is such a vibrant community, and it is growing day in and day out. So few things that we have done. One is renal denervation, which we are doing quite regularly now. We started renal denervation when I was in Patparganj, when we did it with our own EP catheters. But now we have the specialized catheters from Medtronic. We are doing it, and we have got very gratifying result. In fact, this patient we did yesterday, her blood pressure was 180 by 110, and it was consistent, and she was on multiple medications. Today morning, her blood pressure is 90 by 60. We have to actually stop all our antihypertensive medications. Similar experience we had when we started in 2013. Dr. Alka Basheen had sent a patient to us from Max Saket, and we did the renal intervention. She was very particular that the patient should undergo a renal like dialysis. Those were dialysis patients. She was very particular that dialysis patient has to come back to her. She didn't want us to do dialysis at Patparganj. The next day there was a frantic call. You must have done something to this patient. The blood pressure is just low. So we said, what is the blood pressure? She said, it's 120/80. She has never had blood pressure of this. You must have injured the vein, or there must be some hematoma or something. So what is the heart rate? The heart rate is 70. So I said, it's unlikely, but you get whatever. She got a CT scan and everything, and thankfully everything was fine. So it's a very gratifying procedure. Unfortunately, because of the way the Simplicity 3 trial was designed, it did not. But now it's a standard of care, and it is recommended for patients who are uncontrolled on 3 or more antihypertensive medications. Also indicated in patients who do not want to take or are not able to take the medication. Because in fact, the first patient we did with the newer device was, she was an old lady living alone, like not really alone, but there was nobody to take care of her, and she used to forget her medications. So when we used to give her in the hospital, the blood pressure was controlled, but then going back 5-6 medications, actually very difficult even for people like us to remember, and for a elderly person, it's very difficult. So we did the renal innovation in her case, and it was successful. So I think there are various patients where you can offer renal innovation to this. And so other thing that we did was what is called as Micra, the device that is the pacemaker, which is a leadless pacemaker. So it's a small, almost a capsule-sized device, which we implant right into the heart. So that's the upper one, and it's useful for patients who have higher risk of infections. In fact,
it is very useful for patients who are on dialysis because the patient has a fistula and then you put a device here and the fistula will not work. Many a time patients have a fistula which has not worked, then you have got on the other side. So you really cannot choose the sites also. And in fact, one of our patient had a superior vena cava syndrome because of the fact that the SVC got obstructed because of the ICD lead. So this is a device which does make sense in these type of patients, especially who are on dialysis, who have infection, frail patients. And this was a very frail lady. So we did it and it was a 15-minute job, just like Dr. Vibhuti showed the TAVI. So this was in fact small, quicker than that. And patient was very happy with that. And then other thing that we did was the high-end devices that we put. So the good point is, good thing about our country is we get the best of both worlds. So the best technology that is available anywhere in the world. Sometimes we get technologies which are not available in the US. We get it here because our FDA approval is not a necessity in our country. So there are things that are approved in Japan which are not approved in US. We get it here. Similarly, the reverse. There are things that are not available in Japan. We get it here. Drug-coated balloons we have been using for years together. Now only they are getting approved in US. So there are new techniques that are coming up, and fortunately we are able to embrace these techniques and hope to do the best for the patients.
You did a good job without the machine, and I request Ankit Tavos to state he is the champion of the world. Ankit Tavos. Please. Thank you very much. I think keep inspiring us and keep doing good work, right? And we'll have a lot of awards in future as well. So thank you very much for this enlightening meeting. Thank you, Manisha, for wonderful inputs and very good. Every time you come here, you give great inputs and being a good nephrologist, a good physician as well, right? Because because they say that before nephrology, they intermedicine people, right? I think so. We do interact with each other and we discuss a lot of good cases with us. Thank you very much, and we'll meet next month again. Thank you.